Once again, many thanks for being here. We will start this EGFR part 2. For me, it's an absolutely pleasure and an honor to share this session with Professor Rafael Rosell, who you all know very well. And again, we hope to have a very fruitful and active discussion, so please feel free, whatever question or comment you may have, to raise it.
Okay, thank you. Good afternoon, dear colleagues and guests. It's my great honor just in this second session on EGFR, still EGFR and CLC, just to invite Dr. Ignacio Gil Bazo from the Hospital Oncológico from Vitoria-Álava, who will talk on, who will address what to do after the first line therapy in EGFR.
Dear colleagues, it's my great pleasure to be here once more, and I want to thank the three co-organizers, and more specifically Dr. Rodriguez Abreu for his kind invitation. So after everything we've heard this morning in the early session regarding EGFR, what are the new standards or the potential new standards for first line, we have to make another interesting question, which is, okay, how that is going to impact what we do when those patients eventually progress, which is what they are going to do. So these are my conflict of interest, and this is the agenda I will try to cover. As a very brief introduction, I always like to start with this, because if we really look to the past and we think of the accomplishments that we as a community of doctors, patients, industry, academia, etc., have done in the last 20 years, this is really impressive. Today I'm going to be focusing on the last part of the timeline, because it's exactly where we are. We are thinking of how, as I said, we are going to be doing things in the next few months or years once those patients progress to first line. That has already changed. So if we consider treatment sequencing, we should first start with what this patient actually received first line. Second, and this is something that we don't normally do, but I think it's important to think about it, should we treat local residual lesions once we have induced a good response to that first line, whatever it is? Once the patient has a clear progression, if it is a oligoprogression or only brain progression, we should go for locally ablative therapy. That is something that we normally do. But what happens when those patients actually present overtly symptomatic progression disease? We should probably, and this is something for the debate later, should we go for a rebiopsy or a retesting in those patients only if they received osimertinib monotherapy? It doesn't really matter if they received a combination. Should we go for that again? Is there going to change the way we treat those patients? But the question is, how do we actually treat those patients when they progress? Well, if we look at this retrospective analysis with more than 2,000 patients, we see that most of these patients receiving osimertinib first line at the time of progression received chemotherapy, but keeping the TKI that they received. Or they would go for a combination of chemo-IO. In some occasions, VEGF inhibition was also added, and in some other occasions, other agents. And in fact, when those patients are treated with chemotherapy second line, but keeping the TKI, what we see is a better progression-free survival and also overall survival, but it does look like it depends on the specific mutation those patients have in order to see the extent of the benefit that we get. So what about those patients treated with combination first-line chemo-OSI? So those patients, first, at least with the data that we have, less than one half of those patients indeed receive a second line. And this is something to think about. When they do, what they normally get is a when they do and they have received the combination therapy arm, they would go for a non-platinum-based chemotherapy or platinum-based chemotherapy. And we, again, should think about, is this the way we should treat these patients? More chemo at that time? It probably depends on the patient pathway and how long that patient was with chemotherapy in the first line, for how long, when, and what compounds were discontinued, etc. What happens when those patients actually receive OSI monotherapy in the control arm? Well, most of them, the vast majority, receive platinum-based chemotherapy. But we know that the pattern of resistance mechanisms that we get, depending on the first line, may change. And especially, even though we don't see many important changes in the FLAURA2 trial between the control arm with OSI or OSI chemo, we do see some interesting changes when those patients are treated with Mariposa. And it makes sense, I mean, from the biology of the tumor and the two targets that we are acting on. So it looks that those patients in the Mariposa trial seem to develop less heterogeneous and less complex molecularly alterations profiles. So if we consider patients treated with osimertinib first line, we know that around 12% of them will develop MET amplification, around 10% will have secondary EGFR mutations, very similar to what we have in FLAURA2. However, and this is something that Luis also presented earlier this morning, we see that that changes when we treat those patients with a combination with lazertinib and amivantamab. And this is important. We don't really know why that is the case, but it makes sense from the biology point of view, as we mentioned before. So what do we actually have for those patients in second line after progressing to whatever they received first line? Well, this is just a quick summary of the main clinical trials that we have. We only have one phase 3 clinical trial. The rest are phase 2, phase 1. This is important. And let's start with the only phase 3 clinical trial in that setting that we already have with mature data. So this is the Mariposa 2 trial. You know that these patients were allocated to AMI, laser, chemo, or AMI chemo or chemo alone. We know also that those patients were allowed to enter the trial even with untreated brain metastasis, and this is important because we can see what impact the treatment actually has. And primary endpoint was PFS for both comparisons, AMI, laser, chemo versus chemo, AMI, chemo versus chemo alone. Well, the treatment had to be modified in the protocol because of the toxicity in the 3 combination arm. So the primary endpoint that was PFS was met for both comparisons, as we mentioned before, with really good hazard ratios, as you can see there. And this is something that we've never seen before. And this is the first time, actually, that we see that doing something different than chemotherapy, we can actually improve PFS in those patients. Regarding OS, we know that there is also a nice trend, still not full maturity of the curves. We also see time to symptomatic progression, time to treatment discontinuation, and time to subsequent therapy benefit very clearly for those patients treated with the combination arms. Also, and this is something that, again, was mentioned before, we know CNS involvement is important in our patients. These patients benefited also equally from the protective point of view in the first curve, but also in those patients with already brain metastases in the progression-free survival. So we know, and this again is something that has been commented earlier before, we know that adding more treatments is meaning more toxicity. This comes with a cost, and we know probably that in the 3 combination arm, the 3 drugs, probably that will never get to the market and will not be feasible in our patients due to the toxicity. So What else do we have? Well, we also have a phase 2 clinical trial that was also presented earlier this morning, the Tropion-Lung 5. We know that these patients, again, were able to enter the treatment arm with different alterations, but we are going to be focusing on EGFR. And what we know is that these patients showed a very nice response rate, around 43%, with a duration of response around 7 months, more than 5 months, median progression-free survival, and 64%, 82% disease control rate. So again, this drug is able to act on the brains, and we see a very nice data in that subpopulation of patients. We also have the HERTHENA-Lung01 with patritumab deruxtecan after, again, TKI and chemotherapy. Very similar design. Again, these patients were able to enter the trial even with asymptomatic lesions not treated. And what we see is, again, very similar results, around 30% overall response rate. That was the primary endpoint of the trial, and very similar outcomes, nearly 1 year overall survival, and this is important. It looks like, of course, those patients receiving 2 or more lines of prior therapy did not that good, as well as the ones with lower number of lines. This is important again because we see that it looks like, regardless the type of mutation and the mechanism of resistance to the prior line, these patients are going to be presenting very robust responses. Again, we see a clear benefit also in the brain, and this is something that the farther the line we treat these patients with EGFR, the more number of patients with brain or CNS involvement we have. So again, we need drugs that are able to treat those patients in all the different metastatic sites. And, oops, sorry. Well, this is the Harmony A trial, although you cannot see it. And this is a bispecific antibody targeting VEGF and PD-1. And, well, it's the new kid on the block, probably, although we still have the excitement from this data. We know that the design, the type of patients, the population, the drugs those patients actually were able to receive, many of them did not actually receive a third generation EGFR TKI. This is something that would probably not happen in our countries. But this is what we have from this clinical trial. The trial was positive for PFS in the intention to treat, also for those patients with brain mets. And it looks like T790M positive patients do better. Also, patients with less than 3 metastatic sites. However, liver mets and older patients did not that well. Of course, we also have some toxicities that have been described, mainly hematological toxicities with this drug. So what are the potential algorithms that we have? We've seen the evidences. How do we apply these into clinical practice for making decisions with our next patient progressing to first-line treatment? So if we consider a patient receiving first-line osimertinib, again, we should look for only oligoprogressive disease or CNS-only disease, because that probably needs to be addressed in a different manner, the way we have been doing this for a long time, treating locally. What about those patients with actionable mechanisms of resistance? Should we try to treat those patients accordingly? Probably yes, although we probably don't do this every day. And what if that is not the case? We need something else to do, right? We'll see later. There's another approach here, which is, okay, let's focus on the resistant mechanism. That is going to be key for making decisions for our next or subsequent line. Okay, that's another approach. There's a third approach that I found, which is interesting, which is, okay, let's try to tailor treatment first line according to specific biomarkers and some clinical considerations. For example, MET positivity alone, amylaser, first line. Is that okay for us? Second option would be MET negative, but high risk, according to ctDNA positive. Let's go for chemo-OSI, FLAURA2. What about MET negative and low risk? We can rely on OSI monotherapy as a good standard, according to this hypothesis. What if those patients progress? Well, we would just switch to whatever the patient did not receive first line. Well, we have to consider whether this is the way to go or not, especially treating with more chemo the patient that received chemo in the first line. Again, patient by patient decision. And of course, third line, ADCs. Maybe ADCs could be in second line. We have to think about it too. All right, this is getting a little bit more complex. This is another approach, introducing also the option of ivonescimab plus chemotherapy in the Harmony A trial, but potentially is combining everything, sequencing everything in all the way possible. And I think we have to consider whether this is feasible, if we are going to have reimbursement in most of our countries, at least in Europe, and if it really makes sense in our patients. And then, again, we still have the third line options, whatever we did not use in the previous lines, right? And this is the last approach, which is the one I like most, because I think it is considering in a more detail what we should consider for our patients receiving first line, whatever they'd received. New tumor sample, rebiopsy, this is important. I think we are losing that. We used to do that in the past, and we are not doing that anymore, and I think we should come back to that. What about the acquired resistant mechanism? If it is treatable, if it is actionable, we should go for that. Probably yes. What about a clinical trial? We always have to consider clinical trials for our patients. This is science in evolution, right? And then it is also considering small cell or even squamous cell transformation, which is something that happens, and we mentioned before, right? And okay, considering all that, patients with osimertinib, first option, according to this hypothesis, would go for carboplatin, pemetrexed, amivantamab. That would be the Mariposa 2 trial. What about those patients with chemo, OSI first line? They would go for amylaser. Are we going to ever get reimbursed for that in Spain, for example, or in many other countries in Europe? I don't think so. But still, that's an option. And do we have evidence that that's the way to go? We have no evidence, right? And lastly, if we go for amylaser first line, we still have to consider chemo with plus minus bevacizumab. We can also consider ADCs. So this is work in progress. I think we don't have the final answer here, but this is a good start point for the debate. And just some general conclusions. I think the new standard treatments are here to stay. We will see probably how osimertinib in the adjuvant setting impact that first line also. That is something interesting to see how it's going to evolve. The good thing is that we have other options for our patients, not only first line, but also second line. And here is what we need to redefine how to do that and how to do treatment sequencing when we have different options according to patient preferences and patients and disease characteristics. Thank you very much.